1/3 of women have a problem, right? So one in every three women. So if you're sitting down and in the bus and look at 10 women, three of them have a pelvic floor disorder. But it's so untalked about.
Welcome to Venu Health, where women's pelvic health gets real, honest, and easy to understand. Today I'm joined by someone I've known for a very, very long time. I deeply respect Dr. Hussein Warda. He is a fellowship-trained urogynecologist who just moved to Indianapolis, and he offers, of course, the Venu solution for pelvic organ prolapse. Now, he's in Indianapolis building this practice, and if you're a woman navigating prolapse, leaking, painful intercourse, or pelvic floor issues, this is absolutely a physician you will want to meet. So, Dr. Warda, welcome to the program.
Thank you, Rob. Thank you for having me, and it's a pleasure to be here.
So you recently moved from California, UC Davis, amazing institution on the West Coast, to Indianapolis. People are going to ask, hey, what brought you here? You've probably been asked that 100 times since you stepped foot in Indianapolis. So for the ladies that watch this program, they'd like to know, hey, how do they get so lucky?
Well, thank you for saying that. Yeah, it's been a very interesting move, and it's something which is very recent. I had excellent, really very good, productive 8 years at University of California, Davis, where I was an associate professor there. And the move really came from just me exploring new options and kind of trying to grow my practice. And I actually had several interviews all over, and I just fell in love with Indianapolis. The group that I interviewed with is a really very well established group. It's actually the longest running urology group in the nation.
You shared that with me. That was pretty impressive. How long? When did this group get founded?
I think in the late 1800s.
Like over 125 years ago.
Yeah, and it's been just going on and on. Very well established group, and when I just joined, everybody was very excited. As you know, Rob, urogynecology is something that is very limited from a standpoint of the number of providers across the country. And southern Indianapolis, the south part, and going more south until the borders, there's very limited urogynecologists there. So I felt a huge need for me to be able to help patients who really need for our services.
So you're in Indianapolis, but you mentioned you're southern Indianapolis. What practice are you currently aligned to?
So I'm currently aligned to a practice called Urology of Indiana, and they have multiple clinics. They have multiple clinics all over. We have part of our group. There are 3 urogynecologists, but they all practice on the northern side. So there's 0 urogynecologists in our group on the south side, and there's very limited other providers. I think 1 or maybe 2 urogynes in that whole area, capturing the southern part of Indianapolis. So unfortunately, people anywhere from south of the city, they have to travel long distances to be able to get adequate health.
So how you liking Indy so far? Right, you came for summer months, right? And now it's weather's starting to change a little bit. How's the any hot spots that you like currently?
Honestly, it's been a great. I've been here for almost 3 months now. A lot of it is me building my practice, but Indianapolis is beautiful. It's just the suburbs. The suburbs are beautiful. People are very, very nice. I'm really liking my stay and my move, and I'm excited to serve the people in this area.
Well, you've got a amazing staff. Had an opportunity to meet some of the key opinion leaders the last trip that I was there, and so tell us about your staff, what people are going to be experiencing when they book and schedule some time with Dr. Warda.
We have a great team. First of all, they're all very, very experienced. We've been doing urogynecology for a long time in the practice. And we're one of the few practices. We have, as I mentioned, 3 other urogynecologists, But we have as well 9 APPs, like nurse practitioners and physician assistants who help and are specialized in urogynecology, or do part of their job is with urogynecologists. So we have a very significant, strong team. We have a team that performs our tests similar to urodynamics. I'm sure we're going to be talking about soon. We have a team that follows up with all our patients. Additionally, we have staff members who act as urogynecology navigators, and we have one navigator. She's really good. She's very well experienced in urogynecology, and she's the go-to person. So any patient who has any question about urogynecology, wants to reach any help in a timely manner, just has to call one phone call, reach the urogyne navigator, and that person will set her up where she needs to be.
Are you able to say who that is? Because we'll put it on the screen.
Yes, Jody Stevens. She's a great person. She has a lot of experience. She's like significantly such a good person. She's just such a good person, and she's very well versed in urogynecology. I think she's been, and hopefully at some point maybe we talk about her a little bit, but she's been in Indy University. She trained there. She's trained here since I think 2015, and she's trained in other practices, and she's very good at what she does.
So it's always great to have a fantastic team behind you, especially when you're moving to a brand new practice. But if I back up a little bit, you did a fellowship at Harvard. Congratulations for that milestone where you were chosen in a very elite fellowship. But it was urogynecology. So there's a lot of directions that physicians can take right after their, from going to medical school to their residency of where do they want to go into. Even from a resident, you can still branch off to some certain areas, and you chose urogynecology. Was there a patient or a moment that like made you click and go, you know what, this is an area that I really want to focus on?
Yes, definitely. So urogynecology is just such a growing field. And I started my residency, OBGYN residency. And actually, prior to doing that, I did a rotation prior to my residency, right after medical school. So medical school, and then I did rotation with one of the and I think he's one of your good friends, great physician, Dr. Peter Lotzi in Texas, Houston. And I did my rotation there before I even started residency. And that kind of got me hooked. I'm like, wow, this is something that I could like, and I could grow a strong affinity to. Then I started my residency. As you know, you rotate through the different, obstetrics, gynecology, and then I kind of found myself being pulled strongly to like a surgical subspecialty. So by second year, I was like, I really like doing surgeries. I enjoy surgeries. Even in the OB portion, I enjoy the C-sections, 4th-degree repairs. In the OR, I love minimally invasive surgery. And then I did my elective as a third year, and that cemented it. I did my elective at UC Irvine in 2013, and there was it's an extremely strong program, and I'm sure you know some names. I went to observe and joined the team under Dr. Karen Noblet, who's a big name in urogynecology. And after that rotation, seeing how much you could just change people's lives, change patients' lives to the better. Urogynecology, as you know, and we're going to talk about it, Rob, is such a growing, innovative, new subspecialty that needs to reach more people to significantly affect quality of life. So as a urogynecologist, I kind of figured out as time goes, there's an art to it. It's not just surgery. We're not just doing a surgery and we're done. There's a lot of reconstructive. There's a lot of clinical management place in. Every patient is different. You gotta find that nice middle ground where you're treating the patient the best way, but at the same time, you're using your clinical judgment, surgical skills to reach the desired outcome.
All those things probably is what got me excited to be in the space as well, to try to have innovative solutions for women, for surgeons like yourself to then approach and be able to take care of these women. And one of the things that you just brought up is so many women, in fact, of the 100% of women that have been diagnosed with even pelvic organ prolapse, urinary incontinence, I think it's 10 to 15% of those women actually get treated, right? So there's really, really unmet need, which is why we do these type of programs, have people on here like yourself to give people a little bit of a glimpse of what they're going to experience prior to coming to see you, and your passion for the space of urogynecology. So that's fantastic to see. So you were going back to when you were a resident, you were the guy who would raise his hand every time there was a C-section, right?
100% of the time.
Hey,
Every time there's a C-section, hysterectomy.
OR9, and you're like, oh, I'll go.
Yes, 100%. Minimally invasive surgeries, hysterectomies. That was me, it was me for sure.
Well, it's hard not to when you are a young medical school graduate and you go work with Dr. Lotzi. It's hard not to drink the Kool-Aid with that guy.
He's a great guy.
He's passionate about what he does. He's very, very skilled, and that's the part where you go like, wow, this is you're here, and that's where I want to get to as a young medical school graduate. And so I can definitely see, and you certainly have walked through all of those particular steps. What do you feel like if you go back to your time at UC Davis, 8 years? That's a long time. But I'm sure it flew by at the same time. Long time, but flew by. And so tell us some of the what you did there, because I think that's really important for people to realize that you really had a strong foundation that you had left, and are bringing that skill set to Indiana Urology. So love for you to share that with us.
Of course. Yeah, so at UC Davis, it was my first attending job after my fellowship. So it was exciting. I started, as a new attending in a new university, and it was one of the things that I really wanted to do when I was done, from standpoint of teaching as well, Rob. I'm a big proponent for teaching the next generation. So I started with teaching residents, doing their curriculum, starting to hone in on my surgical skills, and the time at UC Davis, growing the practice at University of California, Davis. It's a really strong program where I think it was one of the top 15 hospitals, GYN, in the country. And I was able to come in with new skills, teach the residents. And one of the things that I really take to heart is, before I left, I was awarded with a teaching award from the residents, just across the board, for teaching them during there. And we have collaborated a lot. I did, the cadaveric labs. I grew the robotic. I ran with my colleagues the robotic program, teaching residents how to operate safely. Did a lot of pelvic models, and kind of just grew that program to a place where I felt I was happy with and comfortable. And a lot of my residents still reach out to me if they have questions, or if they're sitting for their boards, or want to ask me about some stuff. So it was a very I think productive and a very important step in my growth as a medical surgeon.
And so congratulations on your award, because that is voted on by the people that you were teaching. So that is certain accolades there. And I've been in the operating room with you, and you take your time. You are precise. You're proficient, but you're also teaching along the way. And of course that always takes time, right? It takes more time. It's harder to do. Much easier for you just to do it yourself, but it really doesn't set up the next generation of surgeons. And so they certainly have to have people like yourself that have dedicated the last 8 years to that, and certainly you were able to improve your skill set as well, because when you're teaching, you need to be the expert, right? And so that's always the thing, that you're always going to try to stay one step ahead of your people that you're teaching, and what's new and what's innovative. And that's one of the things that, we always enjoyed about our conversations.
I want to just add an important part in my teaching. I want to also add that during teaching and as we're doing that, it's always with optimum clinical patient care, right? Like it's never on the where like we're slower in surgery, or where you're not giving the patient. It's still the same patient top care that I would give, including everything that you've said.
Yeah, there's no shortcuts. It is by the numbers. I had a incident with a hockey stick, and so I went to Cooper in Philadelphia, and had oral maxillofacial with his resident. It was done to perfection. Because he's teaching, he's showing, as you're bringing the tissues together, he wants to have the absolute best outcome. And I know you were the exact same way, guiding, teaching, but at the same time ensuring that the patient got the absolute best, no cutting corners, and no quick, returns for that. So if we transition, and we're talking about now the women in Indianapolis, they're gonna come to your clinic. What's the most common things you're seeing right now? In Indianapolis, I know it's very short, brief time, but what are people walking in the door with?
100%. So pelvic floor disorders, Rob, as you know, is a very, very common disorder. And pelvic floor organ disorders or pelvic floor disorders often come in like not singular, but in multiple issues at the same time. And unfortunately, as you mentioned, a lot of patients first don't know if that issue is treatable, and it affects significantly quality of life. So the main things that I see when I started here, and even in California and now in Indianapolis, is pelvic organ prolapse, which means the kind of the weakening of the support tissues of the pelvis, and the organs kind of fall down. Think of it as a hernia. So the vaginal wall has that front wall, the top, and the back wall. So the front wall kind of falls down, that's the bladder. So patients will have what we call a cystocele, or an anterior vaginal wall prolapse. The back wall is where the rectum is, so a rectocele, or where a posterior vaginal wall prolapse. And the top of the vagina, where the uterus may come down, which is called a uterine prolapse. Or if a patient doesn't have a uterus, then it's vaginal vault prolapse without the uterus. So that's one very common thing that I see. The second is urinary incontinence. And that means leakage of urine when you don't want to. And there are several different types of leakage incontinence. The most common ones are stress urinary incontinence. And that's not stress like with stress on yourself, like anxiety, but that's stress on the abdominal wall. So like coughing, sneezing, lifting something heavy, activity, playing tennis, playing pickleball, whatever it may be, anything that you kind of increase that pressure and you leak. And this, as you can imagine, significantly affects quality of life, and patients stop doing their activities that they want. And unfortunately, they think it's part of normal aging, and that's not the case. The other major type of incontinence is what we call urge urinary incontinence. And that's where like patients will have to, use the restroom very frequently. And a lot of times on their way to the restroom, they can't really reach in time. And
They're sprinting.
And they sprint, and then they leak on the way. And that's called urge urinary incontinence. And that's typically really associated with something called overactive bladder, where the bladder is really, really active. And sometimes we have a combination of both, which is called mixed incontinence. But additionally, other pelvic floor disorders include fecal incontinence, like leakage of stool or leakage of, stool material, when could or could not be associated with fecal urgency. We're like, oh, I got to rush to the restroom. And as you can imagine, unfortunately, these are some of the things that people don't want to talk about, and understandingly so. We do a little bit we do pelvic pain as well. And really anything with pelvic floor disorders, we kind of like manage.
So, like I see patients as well, right? Do you have like people that then come in for treatment?
I see if they have that. We have our nurse practitioners, or APPs who may help and do the sessions for that. We have a strong. We don't have our own physical therapist, pelvic floor physical therapist, but we have a strong connection to all the specialized female pelvic therapists. Because as you know, it's a subspecialty as well. It's not any physical therapist. They have to be like trained in the disorders because it's a very complex and very unique field that we are dealing with.
So what do you think are some of the biggest misconceptions that women have about their prolapse or their pelvic floor disorder, stress urinary incontinence, interstitial cystitis, or fecal incontinence? What do you think is the biggest misconception?
That's a great question, Rob. The biggest misconception is it's part of normal aging. My mom had it, my grandmom had it, so I'll just have to live with it. Second misconception is there's no treatment. That and that's one of the things that I very frequently see with my patients. And you've been in my office and saw the thank you letters. And the most common comment on there is like, we wish we had reached out sooner or had surgery sooner. So the non-treatment is like inability to treat, or them feeling that this is something they'll have to live with. I think a huge misconception as well is that if we're going to a urogynecologist surgeon or a gynecologist surgeon, then we are going to have surgery. So a lot of patients are like, but I don't want to have surgery. I kind of want, and we have so many non-conservative therapies that we could offer to patients, like similar to pelvic floor physical therapy, pessaries, medication for some ailments. There are different things that we can do that has nothing to do with surgery. And if the patient is a surgical candidate and they want to proceed, they can definitely do that. I even tell sometimes patients, even if you have a little bit of symptoms, if you come, it could be your baseline, right? It could be your baseline exam. And then we kind of just follow every 12 months or every, 6 months, and we see how things go. And I think a big misconception as well is a lot of women, unfortunately, and patients aren't aware of how common this issue is, because it's something that's not talked about, right? Like you could sit on your family table, family dinner, talk about like diabetes or high blood pressure, but you're not really going to talk about, leakage of stool or leakage of urine or prolapse. It's not something that you want to bring up, and rightfully so. So I think that's one of the things that I really commend you, Rob, for doing this, but like trying to just make the awareness more, right? Like increase that awareness, right?
Unfortunately, you're spot on though. No one's like, oh, I went to the doctor and my cholesterol is, so much better. Oh, great. Or that it's actually high. So I gotta watch what I'm eating. And, mom isn't, or, your significant other isn't raising her hand and go, oh, my bladder dropped this summer,
Yeah, exactly.
Like,
exactly.
oh, what happened? I don't know.
Exactly.
I was running and then I felt a pressure, So to your point, it's not talked about a lot. But there are certainly a lot more groups out there that, Facebook and different chat groups that do some level of support. And of course, there's, different societies that support as well, which is great. But at the end of the day, you bring up a valid point. Even if you don't think it's anything, get a baseline, right? Like you're going to get some really good information, and you're going to get a plan, right? That maybe it's going to start with pelvic floor therapy. Start there.
Or observation, right? Or observation. Or yeah. It's just.
Or it might be that you're just having urge.
Exactly.
We're going to put you on a medication. I'm going to follow you and see if that takes care of it.
It's so common, Rob. It's like 1/3 of women have a problem, right? So 1 in every 3 women. So if you're sitting down and in the bus and look at 10 women, 3 of them have a pelvic floor disorder. But it's so untalked about. And I've noticed that now, me trying to start my practice, I'm going let's say I'm going to visit just a general, a primary care office or or a general gynecology office. And the interesting thing is when I'm going there, like I'm going to reach out to the physicians, but almost 100% of the time, when I go talk to the staff, someone in the staff will be like, I had no idea that that's it. Can I have your card? For like within the staff. That's how common it is.
Yeah, because what do you think is that spot? Is it 40 to upwards of 80? Right? Is that But of course it can certainly happen postpartum, and that's a whole nother conversation. But really, the ladies that are coming to see you, what do you find that range to be in Indianapolis?
So I would say the range is, as you mentioned, 40 to 80. But here's the thing with pelvic floor disorder. It's kind of like a continuum. It could happen anytime, right? And it's so different because there are different risk factors that could lead to that. There's not one thing. So like, for example, you brought up like vaginal deliveries, even just pregnancy, patients who are unhealthy, obesity, smokers, genetically, all these are factors that all add up so if those factors are really high in a patient, a patient who has family history, had 6 vaginal deliveries, maybe an operative delivery, then she's probably going to show up with prolapse in her early 40s. And I've done, surgeries all the way down to like, in the 30s. Versus if patient, doesn't have any family history, prolapse may come a little bit later in life, right? And there's a lot of also symptomatic difference between patients. So I have patients who come in, and we're going to talk about like stages and all that, but we have patients who come in with a less stage and they're really bothered by it, and patients who come with more stage that are not bothered by it. So it's also, there's a lot of how much does it affect your quality of life. So I'll tell patients, if they're if it's not negatively affecting their health, I tell patients, you know what, if it's not bothering you, we don't have to do anything about it. At least, to your point, I saw you, we have a baseline, let's just observe. If it is bothering you, these are the options.
Yeah, great point. Someone who has a grade 2 cystocele and it like, I need it gone. And then someone who has the exact same, and they're like, I don't even notice it.
Exactly. And I wouldn't do, address each one totally differently, right? The patient who's is asymptomatic or is not bothered by it, totally fine.
And it might maybe they have to wait till they get to a 3 or a 4 where they go, okay, now I feel it. And now now I bother it. Okay, great. You're going to be available for that. Okay, so we touched a little bit about fellowship training, and that's a 3-year program that you were a part of. If a lady is looking for a surgeon that is fellowship trained, what does that mean? Explain to our audience what you went through and then how, of course, it prepares you to be a better urogynecologist.
Totally. So after medical school, I did 4 years of OBGYN residency. So as a general OBGYN after that, and I took my boards in that. And right after my residency, I went for 3 extra years of, at the time it was called FPMRS, Female Pelvic Medicine and Reconstructive Surgery. Currently it's urogynecology, that's kind of the new nomenclature.
They changed the letters around.
Yeah, they changed the yeah, exactly.
Same program.
Same program. So the 3 programs, first of all, there's not a lot of programs in the country. I think they're a little bit higher. I think it was in the 40s, maybe. So now I heard recently that's maybe in the 50s or 60s. So it's growing, which is great. But this is a very specialized program, and I joined one of the really innovative programs with a lot of great attendings and a lot of great mentors, similar to Dr. Peter Rosenblatt and Dr. Anthony DeSciullo and a lot of great mentors there. And I don't want to miss anyone, but there's just so much good information. So I learned a lot during that 3 years of fellowship, where it was specifically training on the pelvic floor disorders. It's not like, a generalist is great, but they do a lot of things, right? We're kind of the subspecialized. And luckily, during that time, I was trained with one of the best in the field, and I was trained in a lot of different innovative and a lot of different approaches for the same thing. So I was trained laparoscopically, I was trained robotic surgery, which is using the same laparoscopic ports but using a robot to assist in surgery. I did a lot of vaginal surgery. I did a lot of slings with all types of slings, like retropubic, transobturator, and we did what we call sacral nerve modulation, which is a battery that's placed in the back for treatment of incontinence, periurethral bulking. So my training at Harvard was very focused, and it was very extremely specialized, which I think I was very lucky to join such a great group of people.
But at the same time, very balanced in that you got to experience a lot of different ways to approach a woman's condition, right? Which is they didn't, you didn't go to a program and they're going to go, all right, everything what we're going to do is going to be robotically, right? So that you can actually look at the patient and say, given these risk factors, given all of this information you shared with me, I feel like this technique or approach is going to be the best. It's going to give you the best possible chance of having a great outcome and a better quality of life. So that is one of the things that I love about your program is that when you do leave there, you leave with having touched every different way and technique, so that you don't feel like you're going to get pushed into a corner. This is the one way you're going to do it. You're either going to be a vaginal surgeon or you're going to be a robotic surgeon, but you got to experience both. Which I think is
100%.
really important for the women of Indianapolis, that they have someone who is really skilled at I'll call it both approaches. Either laparoscopic, robotic. I kind of push them together, and then at the same time, vaginal, which truly is minimally invasive. And it might be a great selection for particular patients.
100%. 100%.
So now when you leave your training, then how does that play into your focus? When you talk to the patient, how does that now give you a leg up, an edge to sitting down with the patient?
I think of every single patient as my care has to be individualized. So when you have the options, which you just mentioned, this is how I look at it. I look at my care as patient-centered, patient-focused, and what's the optimum for that specific patient, right? It's not like a cookie cutter, everybody gets one or the other, as you mentioned. And I think being trained in all the different approaches gives me that flexibility and gives me that the option to choose exactly what this patient needs. So if a patient, for example, has a lot of prior abdominal surgeries, has a lot of scar tissue, has a prior history of bowel perforations, I could do everything vaginally, extraperitoneal, treat the prolapse, treat the stress incontinence, do all that without even entering the abdomen. If a patient wants something more, a different type of procedure where we use like mesh, and I know we were going to talk about that, we may go into like the abdomen, and then we may do a more involved procedure. So all that gives me from the types of slings, right? Like I choose my sling depending on how the patient presents. If they have more stress incontinence, if they have more urge incontinence, I may choose one or the other, just depending on that. I choose my surgeries depending on patient's age, patient's clinical comorbidities, because it plays a huge role, as you know. And like some patients are just, safe to go to surgery or safer to go to surgery, and some patients are not good surgical candidates. So if patients are not surgical candidates, we think of something else or think of a more minimally invasive surgery, right? We don't have to do this big surgery. If patients have less prolapse, we may not need to do something that's so invasive. So that, training and me being comfortable and actually practicing that way at UC Davis just gave me that confidence. that I can try to address each patient with whatever works best for them in a way that is the lowest risk for her, and the way to get her the goals that she wants.
Which is fantastic. So it's great that you take that approach. And one of those things that we notice, because we manufacture VNU, is that we get so many ladies that are looking for a different option, right? They want to avoid mesh, or they aren't comfortable with robotic surgery. They're just not, or they're not comfortable with being under anesthesia. Right, that was my mom. So you can do a block, right? You can sit there and we can work around all these different desires for the woman. From your standpoint, you've used VNU now for 7 years. What makes it a compelling choice for women for prolapse?
First, Rob, I want to commend you because going through the whole, and I do want like my audience just to kind of like maybe I'm going to take a minute just to kind of talk a little bit about the history of the prolapse and the mesh, and looking at those signs that say if you have mesh placed, you call this 1-800 number, and it was a whole unfortunate, like in medicine, unfortunately, sometimes there's a pendulum where everybody goes one way and then the problems happen and then everybody goes the other way. So with mesh was started to be used in the pelvic floor disorders and through placement of mesh. So mesh has been used for many, many years, right? And like hernia repairs and sacrocolpopexy, which we can talk about. But it was started to be used in vaginal repair of the pelvic organ prolapse. So placement of mesh through the vagina. And that had issues. I don't want to go too much into it, but a lot of it was regarding like the physicians who were doing it. Some of the physicians unfortunately were not trained in fellowship. They didn't get all the needed training, the skills, and it was overused unfortunately in the early 2000s. 2011, the FDA came out with something called the safety notice. 2016, it changed the category of vaginal placed mesh into a more serious, like what they call category 3. And 2019, which is when we met, the FDA removed all mesh off the market. So unfortunately, this affected significantly everyone, right? It affected everyone who wanted to have a vaginal approach, not going through the abdomen, but they wanted to have a good repair. And I think your perseverance, and a lot of people, and a lot of companies, unfortunately, went out of the market at the time. So many lawsuits, so many stuff. So they're like, we don't want. But your perseverance and you feeling the need and how patients really suffer from pelvic floor disorders and they need something. So at the time there wasn't, and they even removed what we called xenoform grafts, which was grafts that can be like from animals. And there was and there was really a big market that was in need. And that's when you stepped up. So you stepped up with this new technology, new cadaveric graft, skin graft, which is FDA approved. And so it's not, we're using everything under FDA approval, but with the new technology that you brought, Rob, and you worked on, and we've been working together for almost, as you mentioned, 2006, 7 years, it's just continuing to improve, and it's had significant effect on patients' quality of life. Because the VNU, a lot of patients will have very weak tissue. And unfortunately, the repair you don't have something to placate, or if you don't want to use mesh. VNU and the cadaveric grafts that I work with provide this excellent scaffold. So they act as if like a framework where the body grows into it, and then it repairs and it really heals very well. I've had excellent results with VNU. I've had excellent results with the approaches that we do. And what I really like is us working together and the innovation and how the new shapes and the technology and what we do and how we're trying to improve that. It just made a huge difference. Like when I do my reconstructive surgery with the VNU, for example, I kind of make it in a way which is very technical, but it's like I try to keep the vagina midline. Patients don't have pain after surgery, and it's just a good repair.
Well, thank you for that, and I know the audience will appreciate the background and the history, and of course the collaboration, and you certainly understand the science behind it, and there is a lot of high tech science behind it, and then at the same time, how do you explain that in simple terms to the women sitting in front of you?
Well, what I do, Rob, is like I kind of just go down the different options that we have. So I'll sit with patients from the start. Okay, are we thinking conservative or are we thinking surgical? Let's say a patient says, okay, I'm thinking surgical. Okay, surgical. Are we thinking something which just will completely treat the vagina, what we call obliterative surgery if patients are not sexually active and don't want to be? Or are we thinking reconstructive surgery, where we're trying to put everything back up and kind of where it normally is? And then when we reach, if the patient says, yes, I'm sexually active, I'm younger, or I want to do some form of reconstructive surgery, that's where the discussion starts. So are we thinking native tissue? Are we thinking native tissue plus augmenting tissue, similar to, similar to Dermapure, or are we thinking mesh? And those are totally different things with totally different patient characteristics. But at the same time, each one has a benefit and a disadvantage. I'm not a big fan of one type of surgery, for example, is the gold standard for treatment of prolapse, right? Every patient's gold standard could be different, right?
Well said. Yeah, and I think patients that go out to work with other people that are specialized in this field, they will talk about the gold standard. But that's why I really appreciate your approach. Is the fact that the gold standard should be the woman's gold standard, right? What's important to them, and then how are we going to help them get there? And that's why I know the patients of Indianapolis you're going to have a line out the door soon enough here. So given the this modality and your approach, when you talk about VNU and you talk about it being a cadaveric tissue, how do you explain that? Is it a risk? Is it a not understanding? Is it understanding? How do you walk them through, or do you just tell them that you're using a technology that'll help improve their tissue?
Yeah. So I try to keep it like as simple or as detailed as the patient really wants to hear. Some patients are like, I just want to know the big framework and I don't need to know all the details. Some patients want to go into the nitty gritty, and I'm happy to discuss that with patients depending. Typically, how I approach it is, if a patient, let's say we reach that reconstructive. So patients want a reconstructive, but they're anti-mesh, right? They're like, I don't want mesh, which is fine. I do a lot of mesh surgery, but at the same time, it's fine if a patient doesn't want mesh. And then they're like, we want something which is native tissue or native tissue with some augmentation. And that's where my discussion starts. So augmentation, we could use extra tissue or more tissue that has really good characteristics from a standpoint of, like, you don't have, and those are some questions that I get all the time. Could you have an allergy to it? Or can your body reject it and stuff like that? And the technology and the removal of the cells and the removal of all that from that tissue does not lead to that, right? So it really acts just as a framework. It's just a framework for your body to grow into. So I tell patients restrictions, when I give patients restrictions about not after surgery, not being too active. I'm like, this is still a native tissue repair. We still need to wait for your body to grow into it, but this is just giving you the extra strength. And in some patients, when I go in, let's say for a posterior repair for rectus or to just treat the vagina, there's not enough tissue to even placate. There's nothing there. It's just like you're going to be placating like butter, right? So those are the patients as well where this can kind of bridge that area, which has that defect that you really can't address otherwise.
Great way to frame that, Dr. Warda. We talked a little bit about, you had all these thank you notes and you get a lot of patient accolades. Anything you can share with the audience of one that just really resonates, that if someone had came back and shared with you something that was really heartfelt?
Yeah, honestly, every single patient is it just I feel that it affects me this like the same way, right? Every patient will can change one life to live a better life. So to your point, like the last every year I got the Diamond Doc Award for clinical care for patients. Every year while I was at UC Davis, and that was that big honor, and I feel humbled to receive that. But just because it's just something that when you do the surgery well, you take care of patients, you change their lives. I've had patients, and you've been in my office at UC Davis, I've had patients who send pictures of them playing golf again. Or I have patients who are like, I'm finally be able to like just live my life, play with my children. I'm finally being able to leave the house. I had a patient who was 89 and she only leaked when she was bowling. That's the only time she leaked, when she was bowling. That's it. That was pre-COVID. And she was like, I want a sling. I want to get the best treatment so I can continue to enjoy my life, right?
Without a pad. I don't want a pad. I don't want a pad. I don't want to leak when I bowl.
Exactly. And she was so happy. And similarly, hundreds of patients, and I've used, different surgical techniques, but also Venu and Dermapure. I don't know. I think we talked about like what we helped. I don't know. Last time I think you told me what 400 patients or more, or
We were well over 500 that you had a positive impact on, and certainly always appreciate that and appreciate your openness to new technology. It's not that new anymore, but it was at the time. So on a personal note, so women that are watching, what is something that you do or is unique about Dr. Warda that is outside of the OR and the scrubs?
unique.
Yeah,
Um,
yeah, like that people wouldn't ever think that you did, sport or, I mean, pickleball champion or something. I don't know.
Yeah, so I grew up in sports. So I grew up playing several sports. I play a lot of tennis, but I mainly grew up swimming. And I went to, the national competitions in swimming.
At what
Um, I,
age? So when did you do
I
that?
was 19, 19,
Okay.
17 to 19. Yeah, yeah.
At the national level.
National level. Yes, yes. Yep, exactly.
I think do you still
I still,
competitively
I
swim now?
still swim. I still swim through the masters. The masters when so I still haven't joined a team here yet in Indianapolis, but in Sacramento definitely in Sacramento when I was at UC Davis. We went to meets together and it was really fun. Swimming, tennis, scuba diving. I enjoy scuba diving. I enjoy traveling all around the world. I've traveled often, spending time with family and friends, and just
Well, you've got some family dispersed, right?
correct.
Atlanta.
Yeah,
Now it's a little bit now it's a little bit easier. Of course, mom and dad back in Egypt.
correct, correct. Mom and dad back in Egypt. I try to, try to convince them to come here more often, but we try to, do one trip. They come here in wintertime, and I kind of like go there in summer, spend some time on, in summer on the Mediterranean, and just enjoy that time.
No, that's great. That's great. And then we're the ladies of Indianapolis are certainly fortunate to have you, and I think they're going to have a great surgeon, not only compassionate and passionate about what you do, and they're going to be able to have some amazing outcomes. Which at the end of the day, that's if you bring them back to the operating room, you want them to then have a better quality of life, and you have certainly done so. So congratulations there.
Thank you very much, Rob. Thank you. And in medicine, right? You can't work alone. So without people like yourself, and without companies, and without other other input.
You got an amazing team.
Without other input, you can't really get the results that you desire. Like a physician cannot work on his own. We have an amazing team, nurses, APPs, support from industry. It's just like this is, I think, how you get kind of like the perfect result. You're very innovative and always looking for the best for the patients, as well as being our best support.
Thank you for that. And of course, the women are watching that are dealing with symptoms: pressure, bulge, leaking, painful intimacy. Remember, you're not alone. And of course, there are a ton of options. And if you are in the state of Indiana or even Chicago suburbs, doesn't matter. It would be worth a drive to spend some time with Dr. Warda and see if he aligns well with what you would like to accomplish. So, Dr. Warda, thank you again for joining us on VNU Health. Until next time.
Thank you very much. Thank you, Rob.